Assalamu alaikum. Good evening, everyone. I'm Dr. Aisha. I'm here to present for you Dr. Samer Al-Qaisi. I already know that you know him already. So he will be presenting for you thyroid hormone replacement in elderly. Dr. Samer, the floor is yours.
السلام عليكم شكرا دكتور عائشة for the introduction. Thank you so much for staying behind. I know this is the last lecture, so it will be a brief review of subclinical hypothyroidism in older patients. So we will start by looking at the definition of subclinical hypothyroidism, um, discuss potential effects as it applies to older patients, and then evaluate potential risks of and benefits of treatment, and then to provide evidence-based treatment criteria. And I have no conflicts of interest. So to start with definition, we all know what overt hypothyroidism is. Subclinical is when TSH is elevated, but T4 is normal. So this will be the focus of this presentation. The prevalence of subclinical hypothyroidism is quite variable in studies, uh, being between 4 to 15% in population-based studies. And in the US National Health and Nutrition Examination Survey, which excluded people with thyroid disease, the prevalence was about 4.3%. And the prevalence is actually lower if we use age-specific TSH values. So this is a Chinese study from Jiangsu province, which is a seaside province, very rich or very high iodine intake. They had approximately 170 patients with age more than 70 years who had, and 460 patients had subclinical hypothyroidism. But you can see here if we use, so the authors here applied age-specific TSH cutoff, and the upper limit of TSH in that study was 11.5, much higher than what we're used to, and you can see that when this is applied, the prevalence of subclinical hypothyroidism drops from around 30% to 3% in the elderly. So very significant change. Okay, so what is a normal TSH level? Um, so TSH is not or the TSH reference range, it's not a one size fits all for all patients. And it does actually change with age. So again, if we look at the enhanced data, the upper limit of TSH, the 97.5th percentile in elderly patients, you can see that in 70 to 79-year-olds, it's up to 5.9, and people older than 80, it can be up to 7.5. So as we get older, what happens is the TSH curve shifts to the right, and you can see it here in the dotted line. It becomes a little bit wider and it shifts to the right, as opposed to the younger patients where the curve is taller and more to the left. And and what I wanted to show you here again from the enhanced data, the prevalence of people with high TSH. So if we look at TSH greater than 4.5, you will see that in younger patients aged 20 to 29, we have only 2.5%. But if we look at 75-year-olds and above, it's 15%. So very big difference from 2.5 to 15% if we apply single cutoff more than 4.5. In terms of differential diagnosis of subclinical hypothyroidism, it's the same as hypothyroidism, but please remember that up to 60% of patients will have normal TSH on repeat testing. So it's very important to repeat the test and make sure this is not just a transient elevation in TSH. Okay, so let's discuss the potential consequences of subclinical hypothyroidism. So we will focus on progression to overt hypothyroidism, cardiovascular disease, discuss mortality and then neuropsychiatric symptoms. In terms of progression, the annual progression rate is around 2 to 4%, and the cumulative incidence is actually much higher. It can be up to 50% over 10 to 20 years of follow-up. And the risk of progression can be higher in patients with a higher baseline TSH and in patients with a higher TPO antibody. Also, the underlying etiology of subclinical hypothyroidism is important. So people, for example, with partial thyroidectomy will have a fixed defect in TSH, and TSH will usually remain stable, whereas people with autoimmune thyroid disease tend to progress. And also keep in mind that TSH may recover, so you may get spontaneous recovery in the next couple of years, especially in patients with negative antibodies and TSH less than 10. And and again, we go back to the importance of reference range. So this is the Wickham cohort study from the UK, which had approximately 200 patients, mean age 77 years, and they followed those patients for approximately 8 years. The serum TSH during follow-up increased from 4.7 to 6.2, and the prevalence of subclinical hypothyroidism, if we use the traditional reference range for TSH, went from 3.5 to 9, so approximately threefold increase. However, when we apply age-specific TSH reference ranges, the prevalence was really stable at 2% at both time points. There was no difference. In terms of cardiovascular disease, coronary heart disease risk is increased in some observational studies. In a meta-analysis of 7 prospective cohort studies that included more than 2,000 patients with subclinical hypothyroidism, there was an increased risk in coronary heart disease in patients with TSH above 10. However, patients who had a TSH below 10 did not have increased risk. And this is shown here in the diagram. So people with a TSH below people with a TSH below 10 did not have a problem, whereas people with a TSH above 10 had a increased risk of coronary heart disease. There was no difference in terms of age stratification. So older people did not do worse than younger people. And what about heart failure? This is a pooled analysis of 6 prospective cohort studies, uh, more than 2,000 patients with subclinical hypothyroidism. Again, there was an increased risk of heart failure if TSH was more than 10. And the risk persisted after excluding patients who had existing heart failure or atrial fibrillation. In patients with lower TSH, between 7 to 10, there was no significant increase in heart failure risk, and there was no increase at all in patients with a TSH below 7. Um, okay, let's talk about stroke. This is this is an analysis of 17 prospective cohort studies, uh, about 3,500 patients with subclinical hypothyroidism. There was no significant association between subclinical hypothyroidism and stroke. But in subgroup analysis, there was an increased risk in patients younger than 65. The issue about this study is that the number of events is actually very small. And you can see here in the blue arrows, for example, the number of people who had a stroke in the 18 to 49-year-old group, there were only 3 events, but it was significant. And this was the same for overall stroke and fatal stroke. So significant, but small number of events. What about lipids? So there is a association between elevated TSH and increased lipids, especially total cholesterol and LDL cholesterol. The Colorado study from the US showed that there was an increase in lipids in people with subclinical hypothyroidism. These are patients who had a TSH between 5 to 10, but the results were not stratified by age. Perhaps a more accurate description of this issue is a pooled analysis of 16 studies with more than 3,700 patients with subclinical hypothyroidism. It's shown here in the lower panel. Total cholesterol and LDL cholesterol were not increased in patients with subclinical hypothyroidism, and they even did subgroup analysis for patients older than 70, and there was no difference. So this was a negative study. For mortality, we have conflicting results when it comes to subclinical hypothyroidism. A meta-analysis of 4 prospective studies that included 136 patients with subclinical hypothyroidism aged between 80 to 109 years, so so much older patients. And subclinical hypothyroidism did not actually impact 5-year mortality risk. And the main study, or one of the larger studies in this analysis, was a study from the Netherlands, the Leiden 85 plus study, which had 30 patients aged more than 85 who had subclinical hypothyroidism, TSH between 4.8 to 10. And mortality actually decreased as TSH increased. So they saw if you like, a reverse relationship between increasing TSH and mortality. And this is shown here in this diagram. So as TSH goes up, there is a decrease in mortality risk. As T4 goes up, the mortality increased. Uh, Another meta-analysis of 11 prospective studies that included 3,500 patients with subclinical hypothyroidism, and the median follow-up was between 2.5 to 20 years. And the mortality here is a little bit different. So we have in the top panel on the right, coronary heart disease mortality by TSH. And you can see that it's actually increased when TSH is above 7 and above 10. So mortality is increased. And total mortality was unchanged, regardless of TSH level. In the lower panel, it's looking at mortality by age group, and there was no difference in coronary heart disease mortality when stratified by age, with the exception of patients aged 65 to 79 who had an increased mortality. However, total mortality was not increased. So very, if you like, very different outcomes from different studies. And other potential consequences of subclinical hypothyroidism include possibly increase in body weight, neuromuscular symptoms like weakness, fatigue, and cramps, neuropsychiatric symptoms, and Alzheimer's disease. But there's really not much evidence to support that subclinical hypothyroidism increases any of these risk factors. So what about thyroid hormone replacement in elderly patients with subclinical hypothyroidism? We don't have a lot of evidence, but potentially we want to see if there's any difference in symptoms, signs and symptoms, in terms of cardiovascular outcomes and lipid changes. For lipids, very limited evidence suggests that there's no clear benefit when TSH is below 10. For cardiovascular disease, there's very limited evidence of reduction. So for hypothyroid signs and symptoms, there's no difference when TSH is below 10 in most studies. This is a meta-analysis of 21 trials that included almost 2,200 patients. And the TSH level was between 4.4 to 12.8. And there was no change in quality of life or hypothyroid signs and symptoms with treatment. And the largest trial in this meta-analysis uh, had had older patients with a mean age of 74 years. Their mean TSH was not too high, it was about 6.4, but there was no difference in signs and symptoms of hypothyroidism after 1 year of treatment. And they also did a subgroup analysis for patients above 80. They did not show any evidence of improvement. Um, okay, and this is a meta-analysis looking at cardiovascular benefits of treatment, included 7 studies, and all-cause and cardiovascular mortality were reduced in younger patients. It's shown here in the top left panel. Patients less than 65 to 70, they had some improvement, but no benefit in older patients, which is in the lower panel. In a population-based cohort study of subclinical hypothyroidism, where TSH was between 5 and 10, the mean age was 62.8 years and follow-up very short, up to 1.6 years. Um, there was lower major adverse cardiovascular outcomes in levothyroxine-treated patients. And you can see here the hazard ratio was 0.88, including patients who were older. But if you look at the confidence interval for the patients older than 70, which is uh, the very bottom the bottom square, you can see that the confidence interval goes up to 0.98. So it's a very marginal improvement in outcomes for older patients. Okay, so when to treat subclinical hypothyroidism in older patients? Definitely when TSH is above 10, we would consider treatment to reduce the risk of MI and progression to overt hypothyroidism. When TSH is between 7 to 10, we may consider a therapeutic trial if there's convincing symptoms of hypothyroidism or if the patient has a goiter which is increasing in size. When TSH is below 7, most guidelines would recommend no treatment, and this is age-appropriate TSH, usually recheck in 6 to 12 months. Once we start somebody on levothyroxine, we want to start very low dose and then go slowly, usually 25 micrograms, and adjust the dose every 6 to 8 weeks by 12.5 to 25 microgram increments. And we're not really aiming for a completely normal TSH. And if somebody is elderly, a TSH between 3 to 6 is quite acceptable. So to conclude, subclinical hypothyroidism is overdiagnosed in older patients using the standard TSH reference intervals. And TSH goals are really age dependent, and the upper limit of normal in older patients can be up to 7.5. And treatment is not really necessary until TSH exceeds 7 to 10. If we start treatment, we want to go very slowly and be careful not to overtreat patients. And just to tell you finally that in clinic, I think we should be looking out for patients who were started on levothyroxine, older patients with subclinical hypothyroidism, and then really try to find out the baseline TSH and find out if there has been any improvement in treatment, and if not, maybe try to de-escalate and discontinue therapy. I have done this a few times in a number of patients with very good outcomes, where the baseline TSH returned to less than 10 with very little in the way of signs or symptoms of hypothyroidism. Thanks so much.